So, hello, good morning, good afternoon, and good evening. This is Jia IMG from China, and I'm very glad to co-discuss the case from today from University of Miami. And let's give a very warm welcome to Dr. Perry and Dr. Tajera and also Dr. Rehan to give us a very short introduction about their program and also about their hospital.
Claudia, you want to lead off? Introduce yourself.
Sure thing. Hi, everybody. I'm Claudia Tejera. I'm one of the chief medical residents at University of Miami in the Palm Beach campus. Welcome, everybody. Thank you so much for joining us, and thank you so much for the organizing team for inviting us. It's such a pleasure. So a little bit about myself. As I said, I'm one of the chief medical residents. I just matched into pulmonary critical care. I'm going to UAB, and I'm so excited about that. Things that I like to do on my spare time, I do like to enjoy time with friends and family. I know that this is a tradition, so my favorite cuisine, it's Indian cuisine. I do like Mexican, but Indian cuisine, it's always my go-to. It's comfort food.
Oh, that's so awesome. Yeah. Anything spicy, Indian, Mexican, Chinese is always great for me. So anybody that rotates with me, I always buy them some spicy food. I think Yasmin. Remember we got on Teams, we got Indian food once. Jody, can you introduce yourself as well?
Yeah. Hi everyone, I'm Jody Perry. I'm a PGY2 here at the JFK Consortium of UM in Palm Beach County. Originally from Miami, so really love the warm weather that we've been having. A little bit about myself, I enjoy doing just about anything outside, which is why I stayed in South Florida so I could enjoy going to the beach and that kind of stuff. In terms of favorite cuisine, I really like Italian food and actually just made some homemade tiramisu for the first time last night. So that was pretty fun.
Oh, brilliant. There's quite a bit of Italian cuisine which you can get spicy too. So that's you can add that to my list of favorite cuisines there as well. And we also have Mohammed Rehan. Are you able to unmute and introduce yourself? And Mohammed's going to present the case today.
Hey everyone, my name is Mohammed Rehan. I'm one of the PGY2s also at the University of Miami JFK in Palm Beach County. A little bit about myself, like I said, PGY2 in terms of like the cuisine that I like. It's also Indian food, but pretty much anything that's spicy, you'll pretty much find me over there. And then in my spare time, I like to spend time with friends and family.
All right, brilliant. And tell us a little bit about Palm Beach. Now, you're not in, I was just made aware you said you're not actually in Miami, but you're in one of the suburbs. So maybe Claudia lead off with how is Palm Beach or how close to Miami and what's unique about Palm Beach?
So I lived in Miami for a couple of years before moving here, and I can completely say that I love Palm Beach. It's a little bit different in terms of it's like an hour away, an hour and like 15 minutes away from Miami, depending on the traffic. Um, so I think it's way smaller. So that's traffic wise, it's much better. Rent wise, it's much cheaper too, which is always appreciated when you're in training. Um, and overall, I think I do enjoy coming here. It's I think when from my training, one of the things that I enjoyed the most, it's kind of like how easy and how close we are to the beach. So kind of like after a really hard shift or like when you're bored in your house, it's always nice to decompress, to have like a really way out and go and take a walk at the beach and get in a restaurant with like beachfront. So people are super nice. There's like everything that you can think of you can do here. There's like golf courses that you can just go. There's natural parks that you can go and have like a good run or like good exercise outdoor. But there's also the weather and the warmth. So it's the best of both worlds.
The weather and the warmth makes me extremely jealous, but I'm sure in summer it's insanely hot and humid, but for a few months. Jody, tell us this about your program. Like, I assume there's a large mix of IMGs and sort of the makeup of your program, and what made you decide to want to rank this program high or match this program?
Yeah, we have a good variety of both IMGs and um, US medical residents as well. A good array of patients too, because we're in West Palm Beach County. We have a lot of snowbirds that come in. So you have a seasonality about it, but then you also have the locals with a large array of Hispanic and Haitian speaking populations here. What made me rank it particularly, I'm from South Florida, so I wanted to stay closer to family and around the area. I really enjoy the weather. I love going to the beach. Running in a light sweater is nice in January and February. Don't have to worry about those kinds of things. But overall, the community within the program during interviews was evident, and it still is evident in a year and a half in. So really happy with my choice.
Oh, that's brilliant. And you used the term there, snowbirds means people from the north, especially what I noticed when I went down to Florida was a large influx of Canadians trying to escape the winter, the brutal winters up in Canada as well. And Mohammed, what is your favorite thing about this program? What do you think is unique? Because we have a lot of people here today that are ready to submit their rank order lists and probably um, probably pondering over your program, deciding whether or not to rank it high in their list.
So I actually had the luxury of knowing someone in the program before when I was in the interview process, and I think through that and throughout my own interview process and talking to the faculty and the resident sessions, and I think one of the biggest things, and it's evident to this day as well, I think one of the biggest thing and the most unique thing of the program was, sure, I mean, in every residency program, we're going to have an educational opportunity. There's going to be some sort of structured curriculum for you to follow, to kind of make sure your clinical success. And I think our program actually places a lot of emphasis on, growth as a human being as well. So I think the humanistic nature of medicine and understanding, a lot of these people are coming to you in the worst possible times of their life. No one, quite frankly speaking, no one wants to be in the hospital and spend time in those situations. And there's actually an article that one of the program director actually shared earlier in the year with us when we started out. And we basically made a comparison between how being in the hospital is pretty similar to being in jail. So it was a pretty cool article because, if you think about it, you're pretty much confined to a bed in a room. You can't go and do certain things on your own, whether this is more of a safety concern, but nevertheless, the parallels were there. And I think, coming in with an understanding that, you have people that are going through the worst possible times in their lives, and you are responsible for, kind of getting them through it. And at the same time, I think what it avails us is an opportunity to kind of reflect and sort of see, where things fall in the big scheme of pictures. And I think so for me, I think the biggest thing and what attracted me to this place was just the emphasis on growth as a human being, and then a physician as well.
Wonderful, wonderful. I just love that reflection where you feel you're truly supported, especially with your EQ, and that IQ is not just focused on primarily. So wonderful to hear. A very attractive part of your program that I'm hearing. And we have a case there. Mohammed is bringing a little bit of his program to CP solvers with this unique case from University of Miami, JFK. So we'll start with the first aliquot. And Anmol, are you able to share the whiteboard? And then Gia, you want to take first stab at it, and let's see what we have.
Okay, sounds great.
Hi. Can you help with the blanket? Okay.
Are we ready to start? Okay, so I'll be presenting the first part of the case, and then Mohammed, Dr. Rehan will go ahead and jump in the second part. So our patient is a 73-year-old male who presented to the ER for complaints of dizziness and fatigue. Do you want me to continue on with the HPI or
Oh no,
start
I
with
think
that?
I think that's a great start and something we can sort of start dissecting. What are you thinking about, Gia, this time?
Yeah, currently, I think there are a lot of possibilities for this case because this patient is in an old age, and also the dizziness and the fatigue is not like very specific complaints. But for sure, in old patient, we are worried about something related to the cardiovascular system, like syncope, and also related to malignancy, which can also lead to the fatigue. And when we talk about fatigue, probably we may think about something like anemia and something like malignancy, as I mentioned before.
Absolutely, yeah.
How do
We
you?
had,
Mhm.
yeah. Oh, sorry. Did you have something else to add, Gia?
No, I just want to invite you to
Yeah.
discuss.
Absolutely. I absolutely love that start because I think it's too early in the game to invest too much cognitive energy in trying to decipher what's going on here. But two things pretty much you have two disorders here, which very much one can trigger the other. So is this dizziness causing this fatigue or fatigue causing lightheadedness slash dizziness? So a couple of areas that you had sort of pondered over. Could this be neurological? Could this be vascular? Could this be associated with the autonomic system? Not quite sure, but the patient being using epidemiology and using the age, this patient, we don't know if they have risk factors for vascular disease. So could this be a cerebrovascular condition? And then fatigue is interesting. Even yesterday's case, it was just insane to see that inflammation from a malignancy could cause weakness. So I always like to ask, especially when you are trying to do hypothesis directed questioning to the patient. The patient says, I have fatigue. My hypothesis is, do you feel weak or are you weak? So when you feel weak, you have full motor strength and capacity, you can move, but I just feel like I'm blah. I can't do anything. I'm demotivated. I can't do anything. So, or I can, I can move. I have energy, but I just can't move my arm. So there's something maybe local that's going on. So is this a generalized condition or is this something focal to a certain area of the brain or peripheral nervous system? So we'll get into that with the next aliquot. So back to you, Jody.
Yeah, so like I said, he's 73 years old. He has no known past medical history and he follows up regularly with his primary care, who is actually the one who sent him to the ER for further evaluation of these complaints of lightheadedness, dizziness, and fatigue. He had reported that since having COVID about 3 months prior, he has been persistently fatigued and had episodes of dizziness. Prior to having COVID, he was relatively healthy, he was active, and actually still working.
Actually, we can stop there. This brings up a really important point. Gia, any thoughts? Now, COVID
Yeah.
is being brought into the picture.
Yeah, I have limited experience in COVID treatment, but I'm thinking of like any complications like patient can have after they infected with COVID. Is there any like possibility that the COVID infection can impair the patient's like auto neurology system or impair their like maybe cardiovascular, but I'm not sure and I'm not very clear in that area. Yeah, but since this patient is always healthy and sounds like the COVID infection is a trigger, and also important to know any like treatment the patient received, any vaccination. I think all of this could be maybe related to this episode. And I also agree with a comment in the chat that we should know more information about the dizziness, about what exactly the patient has for each episode. Did the patient have loss of consciousness, and is it just dizziness, or is there any accompanied symptoms? How long did this episode last, and is there any triggers, like whether this happened when the patient stand up? All this information is probably we can help us to make the further differential diagnosis.
Absolutely. A couple of really important points there. That's why I kind of wanted you to start off. And yes, we all have limitations of experience. Maybe we haven't seen cases like this on VMR. What VMR allows us to do is then be able to listen in on all these other cases from around the world and learn from them, because we don't have the capacity to see all these patients. So it's like almost like we're seeing this patient along with our friends from University of Miami JFK. And there was an interesting tweet yesterday about long COVID, and the data suggested that just preliminary diagnosis of long COVID can miss a lot of things. So one thing we need to be careful with, that we don't just rush to judgment and force a diagnosis and say like, oh, this is long COVID, and miss something. So during COVID, we've seen a lot of underlying disorders become eventually unmasked or clouded, our judgments clouded by long COVID. And we just like, this is long COVID, okay, send the patient out, and then only for them to come back with some serious inflammatory disorder, maybe some downstream effect or sequela of COVID, like multi-system inflammatory syndrome or other sort of associated, like you said, cardiac effects like cardiomyopathy or hepatitis or things like that. The other thing is, whenever you see a patient 73 years of age, we do have a tendency, and I have gone through this, where we do have a bias of ageism. Okay, 73-year-old, is this your normal state? No, the patient's telling you this is new, but are you like this all the time? Maybe they're debilitated, maybe they can't get out of bed, but we have this inherent bias, and I've seen it, and it's one of the things I try to correct. So the patient's telling us that this is new, and before this, I was fully functional, I was driving a car. So it's always good during your questioning to ask, what is your baseline of functional status? So I just kind of wanted to get that in there. But going back to dizziness, what at this point, I won't say it's a pivotal point that is going to get us to a diagnosis, but I would say is our major thing right now that we need to determine is this something dangerous? So when you have dizziness, you want to also associate that with, is the patient having any neurological deficits? Is this patient having any diplopia? Is the patient having ataxia? You want to do a gait test. Like yesterday, Reza talked about the get up and go test and see how the patient's doing. Is there any associated sensory deficit? So in the examination, or if Jody will elaborate more on the HPI, are there associated symptoms along with this that would raise our suspicion for a central process? If there is a central process, we need to get this patient to an MRI and rule out something like a TIA stroke or something along the lines. More benign causes of dizziness that we can then also explore. There could be labyrinthitis, where your hearing will be impaired. Meniere's disease could also be something like this as well. We also have to wonder about posterior circulation also be involved, where you can get dizziness as well. But still, we're early in the game. There's nothing to pivot on to the diagnosis. I still would explore, and I'm really interested in the vital signs to see, like G had mentioned, orthostasis could be a cause as well. And we'll see what Jody has more for us in store. Back to you, Jody.
Yeah, so he reported that it was episodic dizziness, and he hadn't noticed any specific pattern associated with it. He described it as feeling woozy, and denied any sensation of the room spinning or lack of balance or coordination during this time. He said that it was usually relieved by eating or drinking something. but it had been waking him up in the middle of the night. I think I'll stop there for a minute if you want to.
Oh, sure. What do you think this does for you, Gia, with now these complaints?
Yeah, I think like without the sensation abnormality or coordination abnormality, I may kind of relieved that these patients probably don't have severe CNS dysfunction. But very interesting, we have a clue that this patient's symptoms is relieved by eating and drinking. So probably easy to relate to the hypoglycemia. I think this like my maybe most priority to rule out. And I think if it is due related to glucose, probably I would think about some neuroendocrine tumors in the pancreas, which can lead to this.
Yeah, I agree with you. I think this sort of is a point to pivot onto, and I think even before we get into maybe a neuroendocrine tumor to see if this patient has a history of diabetes or not. And we don't have medications, we don't have past medical history yet, so you can have hypoglycemia. And when we define hypoglycemia, CPS has a very good a schema on hypoglycemia in a non-diabetic patient versus a diabetic patient. But this definitely is somewhere where we can start exploring and determining what may be going on. So we may be in the domain of metabolic disorders causing this. And it's kind of interesting that usually you alleviate altered mental status, fogginess, or difficulty with functioning with hypoglycemia. But this lightheadedness, dizziness, I guess the sweating is typically, I don't see that there. But just before that, the chat was talking about maneuvers. I love doing these maneuvers to determine if you have a central process, which is the HINTS exam, and also doing the Dix-Hallpike maneuver. So both of those can be very helpful in your physical exam, trying to determine the etiology of dizziness or vertigo, central or not. So those are two things I just wanted to mention. Somebody also mentioned in the chat. But getting back to now, I'm not going to go down that rabbit hole right now, but I would do that in the exam as well, because again, you could have two processes going on. What if there's hypoglycemia? I do simulation where I give the residents a low glucose, but there's something else going on as well, just to sort of have them go off course and go down that rabbit hole and completely miss an underlying disorder like adrenal insufficiency causing hypoglycemia. So that's something else that could come into the picture. But I'll swing it back to Jody. Are you giving the next aliquot?
Yeah.
Okay.
So episodes are associated with sweating and hunger. He also says that since this all started, he's had a decrease in his appetite and consumption of food, but he denied any specific abdominal pain, nausea, vomiting, change in his bowel habits. He also denied any palpitations, presyncope, confusion, urinary or bowel incontinence, and any postural hypotension or neurological deficits specifically. In terms of his past medical history, he said he had none. He was very healthy, like I said before. He was active and working. He reported taking no medications, only an over-the-counter multivitamin, but no other prescribed medications. In terms of family history, he does have a family history of type 2 diabetes in his mother, and he's unsure about his father's family history. He, I guess, wasn't in touch with him. And then social history, he denied ever smoking. He denied using any alcohol, no drugs or vaping. He lives with his wife and was previously still working, but isn't currently. And he had no allergies.
Will we also go on to the exam and then stop there?
I'll actually let Dr. Rehan take over for that one.
Okay, great. Thanks, Jody.
Thank you.
So in terms of the physical examination, the blood pressure was 150/72, heart rate of 70 beats per minute, respiratory rate of 17, and he was saturating 98% on room air and afebrile with the Tmax of 97.8 degrees Fahrenheit. So upon further physical examination, generally wasn't in any acute distress. It was well developed, well nourished. In terms of his head, eyes, and next examination, pretty much unremarkable. Pupils are equally run and reactive to light and accommodation. Extraocular movements were intact. There was no scleral icterus. There was no jaundice. I didn't have any JVD that was noticeable at that time. For a cardiovascular examination, no murmurs were appreciated. He had regular rate and rhythm, normal S1 and S2. For lungs, clear to auscultation. He didn't have any V's, any rales, cricles, or rhonchi that would be appreciated. For the abdominal examination, it was soft, non-tender, non-distended, positive bowel sounds were present. He didn't have any organomegaly that could be appreciated. In terms of neurological examination, so no outright focal deficits were appreciated. The cranial nerves 2 through 12 were intact. The reflexes were normal. Did not have any sensory or motor changes, gait, tone, and strength and coordination, all within normal limits. Hintz exam was unremarkable, as well as the Dix-Hallpike maneuver did not elicit any evidence of nystagmus. So grossly, the physical examination was unrevealing. In terms of orthostatic vitals, they were negative as well. He was not orthostatic upon presentation.
Yeah, I'm just going to chime in. Such a great presentation, Jody and Mohammed, and such a great history that you've taken. It just speaks volumes for your programs that you're trained to elaborate such a history from a patient, especially with all the review of systems, which can rule out a lot of different things, and also such a rich exam that you did with the patient, full of details. And you actually did the Hintz exam and the Dix-Hallpike. So I just want to applaud you on that. That definitely helps in trying to decipher this case. I'm going to swing it back to Gia to see what she thinks with this new data.
Yeah, thank you for this great presentation. I think currently we didn't get like much more positive information, but I think all these negative findings also help us because like no medical history, no significant current medications. This kind of help us rule out possibilities of hypoglycemia triggered by other medical conditions or any medications. However, I think this is very interesting. We found the patient's mother has type 2 diabetes. Although it is like not so likely, but is there any possibility that this patient took some medications from his mother's medication? I think it's a possibility, but not so likely. And also the negative finding in the physical examination maybe help us in further rule out the abnormality in neurology, and also help us rule out like probably like conditions related to the adrenal insufficiency. Because I think in that situation, probably patient may have lower blood pressure, may have some appearance in the skin. So currently, I think my focus is still on the pancreas in the insulin, and also I think Dr. maybe Black mentioning the chat box, like in the old patient, we have to consider the PO because the patient have decreased appetite. Is this related to this hypoglycemia and further to the fatigue? So if in that case, what is the real reason contribute to this decreased PO? I think malignancy still is a consideration in the old patient, in an old patient. And apart from that, and because this patient don't have any liver disease, so probably like the hypoglycemia related to the liver conditions is less likely, and like neuroendocrine tumor related to the pancreas is still my like priority at this point.
Well, first of all, I want to applaud you, Gia. A remarkable like dissection of the data and analysis. And as we get deeper into the application season rank order list, whatever program you end up at, we'll be very lucky to have you with the level of the ability that you have with trying to understand cases is remarkable. So that just tells us the academy does serve all of its members well and sets them up for success in training. So I don't have much to add. I think you really, at this juncture, I think I also want to highlight Dr. Black had mentioned as introduced himself as a hospitalist who see these things. So definitely thinking if you try and start just theoretically, laying a theoretical foundation, hypoglycemia, what Dr. Black would also say would be that first of all, that if we don't have a glucose yet, but we're anticipating a low glucose, but if we have a normal glucose, that doesn't essentially blow this out of the water as a potential diagnosis. But yeah, you want to avoid pseudo hypoglycemia because I've had patients with problems with circulation at the fingertips and we get these false readings. One other thing that I worry about if he's non-diabetic in a senior person is access to food as well. So we also have to make sure what is the social background? How are they taken care of? Can they drive to the supermarket, get food? Are they getting adequate nourishment? They're not just eating fast food. Is somebody cooking for them? Are they getting their appropriate daily nutritional intake as well? We saw medications. You mentioned there not much medications there that could also bring on hypoglycemia in a non-diabetic patient. Like there's meds like beta blockers could do that, tramadol, and so on. Somebody mentioned access to metformin. Access to sulfonylureas. You may take a medicine by accident. I had a patient that took his wife's medicine by accident and ended up getting hypoglycemia. So those sort of social factors we have to think about as well. But I think lab data will be very helpful in this case. Gia, what would you want in this patient if you were admitting this patient? What kind of test would you want?
I remember, since we can test the insulin and CPAP, and also test the glucose at like specific time points.
Absolutely, yeah. So getting insulin level, C-peptide, sulfonylurea level as well. And then the rest of the chemistry, CBC, would be very helpful. At this point, adrenal insufficiency, less likely. Occasionally you do see that. But then let's start with this preliminary data and then see what we have, and then we can move beyond that if we don't gain much traction from these tests. Back to you, Mohammed.
Yeah, sure. In terms of hematology on labs, his white count was 10.1, hemoglobin of 13.5, hematocrit of 39.9, and platelets of 324. In terms of the basic chemistry, sodium of 131, potassium of 5.1, chloride of 94, bicarb of 27, BUN of 18, and creatinine of 1.05. And the glucose on the basic metabolic panel was 130. Moving forward, in terms of the liver function test, the AST level was 48, ALT of 47, alphas of 121, and TBL of 0.6. His albumin was 3.2.
I guess, should we stop there, Mohammed?
You can.
All right, Gia, this lab panel is very interesting. Something does come to mind. I think we are now rapidly getting to a destination, and definitely this could pivot us to a diagnosis.
Yeah. I'm thinking like first the CBC is generally normal. The WBC is like just in the borderline, but not like something can catch us eyes. But the electrolytes, the sodium, I actually when I saw this number, I may not like so it may not so make me worried because I think for patients I think it's just like borderline abnormal. And otherwise, for the potassium, is it abnormal, like more than 4.5? Yeah, probably this is something I may worry, and also considering the patient has a high blood pressure, which he didn't have uh, like the past medical history before. I may also think something related to the Crohn's syndrome, but I'm not very good at interpreting these electrolytes and may need your help.
So yeah, very good highlighting the abnormalities. You're right on point there with, yeah, this hyponatremia. Again, it's a secondary process. Something is currently currently taking place, which is to explain this. So it's not a primary hyponatremia, like you may have somebody like a primary polydipsia and so on causing that, but or tea and toast diet or alcohol intake, excessive alcohol intake, things like that. But uh, what kind of comes to mind when I do see hyponatremia, it can be a signal in somebody. And again, the sugar is normal though. But I was mentioning earlier adrenal insufficiency, and it does have a certain fingerprint in the labs. Hyponatremia is very much associated with that. And when you have a deficiency in cortisol, you do also see if the sodium is low, then in that case you have to exchange, you have to absorb sodium, and then you exchange it for a lot of different things, which could be protons as well. So what may end up happening is you have a hyperkalemia and also a non-ANGAP metabolic acidosis. So hyponatremia, hyponatremia, hyperkalemia, and anagma. I quickly just calculated the anion gap, and it was normal, but the sugar isn't low. And if we look at our illness script for adrenal insufficiency, there are certain things like you may get in primary adrenal insufficiency, you may end up getting the skin rash and so on, which may be present or may not be present. On labs, you may see eosinophilia, you may have orthostasis, which we're not seeing. We're seeing hypertension. But you know what? That's a typical manifestation. You have atypical presentation, so you may not catch the patient in that point where they may have that low glucose or the blood pressure may be a problem. But the usual manifestation would be somebody who's having weight loss and you're having the hyperpigmentation, fatigue, which we have here, anorexia, nausea, vomiting, and so on, but we're not seeing that. But that's the prototypical patient that you have with adrenal insufficiency. Here we may not have this. You may have a patient with a sort of a subacute presentation, may develop a rash down the line. We don't know. And if you think about the most common cause of adrenal insufficiency in the United States is usually autoimmune. Outside the United States, it's TB. And those would be sort of like the causes of this, which I would have to decipher. But even if we diagnose adrenal insufficiency, what is causing this? And the way to diagnose this would be to probably get an early morning cortisol test. If it's less than 5 or 3, pretty much it's a slam dunk. If it's between 5 to 15, then we need to do a stim test in that alongside that as well to determine if the adrenal is functioning. But that's pretty much all I have to say. But we'll see. I think Mengyu and Tand, I'm just looking at the chat. Okay, I think people are pretty much along that line as well. But we'll swing it back to any other thoughts, Gia?
Yeah, I don't have any more thoughts. Yeah,
Okay.
just enjoying your teaching. Yeah.
Thank you. Back to you, Mohammed.
Yeah, so some of the other labs that are somewhat not so pertinent, but his troponin initially was negative. We also tested him for COVID, which is negative as well. and his hemoglobin A1C was 5.2. Interestingly enough, after admission, we repeated his initial point of care glucose was 127, and within 2 hours, the number was now 38.
Wow.
So this was obviously concerning for something causing hypoglycemic episodes. I'll give you guys a minute to sort of ponder upon that.
So Mohammed pretty much pulled the rabbit out of the hat with the low glucose we were anticipating, but we're like, wait, the sugar's 130. How is this? How is this patient? This patient looks like hypoglycemia, but we don't have the number, but now we have the magic number. What do you think, Gia?
I think it's like very magical that patients certainly had this jump down to very huge jump down. So it made me think of like the insulin pulse may certainly release in this patient body, and also make me tend to like insulin lower this tumor more. Otherwise, I don't think there is any other cause that can lead to this jump or this on this glucose.
Yeah, absolutely. Let's see. What do you want to order at this time? Now we have to decipher where are we? Are we this with the patient having hemoglobin A1C of 5.2?
Mm-hmm. I don't know if we will order like insulin or CPAP when the patient has this episode may help for, but probably I would order that, and because I have like a high suspicion for the tumor in the pancreas, and probably I would do some CT abdomen to see can we find anything there.
Okay, sure. And Dr. Black again with a great thought. Critical to obtain the labs during episode of symptomatic hypoglycemia. Absolutely right. If you have ever had a patient on your service with this hypoglycemia, you have to admit them and then do these tests and monitor them closely because of symptoms of hypoglycemia. So it's really important to get these labs during that moment. So we'll swing it back to Mohammed to see if he has this data and maybe more.
Certainly. So that's pretty much the thought process we had at that time as well. And those were the labs that we ordered. So we ordered a cortisol and ACTH level. It was random just to sort of assess where things are at that time, because we're going down this endocrine route with adrenal insufficiency versus some sort of dysregulation of insulin and glucose interplay. So insulin level, C-peptide, proinsulin, ketones were kind of in play. We also obtain a CT of the abdomen and pelvis with the pancreatic protocol to see if there's any evidence of potential etiologies. And Jody's going to pull the images up.
Am I able to share my screen?
Yeah, we'll have to stop screen sharing. And Jody, I made you co-host, so you can pull
Okay.
up the images. But I think Anmol, you have to stop. Okay, very good.
All right, so that was the standard view, and now we're looking at the arterial phase. And lastly, the venous phase. Are there any that anyone wants to see again?
Yeah, I'm not seeing. First of all, the large burden of stool is quite evident, but that's always something I look at. And but going back up near the pancreas, that's what we were interested in, Gia, right? If you could slow it down near the pancreas.
So this is the standard phase.
Okay. I'm not great at reading the pancreas, but I was trying to see if there's anything offshoot. The liver, there's a few spots, sort of hypodense, maybe. I'm trying to determine hypodense areas. But what was your reading or interpretation, Jody?
So just sort of going back on that, the slide that Jody had that on, you could actually see the tail of the pancreas. There was a pancreatic mass. You saw that in all three phases. And when we actually look at the without contrast phase, you could see some hypodense lesions in the liver, primarily in the periphery, but they're pretty much all around. And then that's the pancreas right there. And in the splenic flexure, you could actually see that big blob. It's right underneath the stomach in the section, and then just above the bowel. And you could see that on the sagittal and the coronal section as well. So there was a pancreatic tail mass. And then in the arterial phase, we didn't see any enhancement of any sort. And then the liver lesions sort of pretty much remained hypodense as well. But in the venous phase, interestingly enough, the liver lesions has like this peripheral enhancement, and so does the pancreatic lesion as well. So some of those findings are sort of suggested for some sort of non-hepatocellular causes of hepatic lesions, which could be pretty similar in nature. So there was a concern for metastatic lesion of some sort.
Very interesting. What do you think, Gia? Where do we go from here?
Yeah, I think at least in the city, we found something that we can do to further work up, and also these findings can possibly explain the patient's symptoms. And probably the next step is like how we should do the further investigations to make the final diagnosis. I'm doing. I'm thinking of like a biopsy, but I'm also thinking of what approach we can do this biopsy. Should we biopsy the pancreas or biopsy the possible metastatic liver lesions? Yeah.
Absolutely. And getting back to your first initial couple of thoughts there, thinking of this maybe being a insulin secreting tumor, the test that you had wanted earlier, I think we didn't get C-peptide, insulin level, and insulin growth factor. I think we should proceed with that before we biopsy. What do you think, Mohammed? Do you have that data or anything else?
Certainly, and that's the route we pretty much went as well. So the insulin level is 59.6. The normal is anywhere from 3 to 25 millimoles. The C-peptide was 6.36, which is also elevated, and the normal range is from 0.48 to 5.05. Proinsulin level was also elevated at 965. The normal is anywhere from 0 to 10. And the ketones, particularly beta hydroxybutyrate, was within normal limits. And in terms of the ACTH and cortisol, they both came back within normal range.
Very interesting. Was this done during a 72-hour fast? Forgot to mention that.
So that was actually during the hypoglycemic episodes.
Okay. What do you think, Gia?
Yeah, I think like the elevated insulin along with the elevated C-peptides may inform us this insulin is generated in the patient body. It is not insulin the patient received outside, because the C-peptide also elevated. So seems there is some abnormality like that secrete such insulin, and it is likely the mass we found. And so probably I can guess in the next step we can went to the pathology biopsy these steps.
Absolutely. So you demonstrated that, usually why we do a 72-hour fast is to then sort of bring on or unmask the functioning of that insulinoma. So you want to see a glucose level less than 45, which here you have 30, and then a serum insulin which should be greater than 5, 6. But here, I think the U depends on the units. 59 is excessive. This is extremely high. And like Gia had mentioned, elevated C-peptide as well, which is associated with that insulin. So it's endogenous secretion. And if it's positive, I know for board exams, then they recommend proceeding with imaging. We have the imaging. So the next step, what we would need is, like Jay had mentioned, would be then tissue. So I guess calling interventional radiology and obtaining pathology would be the next order of business. What do you think, Mohammed?
Certainly. So we got some of our colleagues involved in GI and hematology oncology to sort of help us through the process. And so the first thing the patient underwent was an endoscopic ultrasound with a fine needle aspiration biopsy of the pancreas. And then the neuroimmunostaining came back positive for a neuroendocrine tumor in the primary pancreatic lesion. And then the staining was positive for synaptophysin and chromogranin and CD56, all of which were pointing towards neuroendocrine nature, and in the clinical context, suggestive of insulin.
Incredible, incredible. Wow. I'm so glad you pushed through and not just sort of like use COVID as an explanation for weakness, because I think I had COVID for the second time. I was still very weak, but you always have to remember there could be something bubbling under the surface and you don't want to miss it. So I really applaud you for sticking in there, especially the normal glucose at the beginning. You're like, oh, the case smelled, walked, talked like hypoglycemia, but the glucose was normal, but then it dropped. So that was great, and I applaud all of you for tremendous care of this patient, and then determining exactly what was going on, what we call that getting to the endpoint diagnosis, rather than making a preliminary diagnosis and then sort of shutting down the diagnostic process. Do you have any reflection on this case? This is a great learning case
Yeah,
concerning
sure.
hypoglycemia.
I think just as you say, sometimes we can't contribute to these symptoms to like just it may the etiology, but we should definitely dig deeper. And I'm also curious, like if I encounter this patient, all these labs and physical examinations are negative initially, what I should do? I don't know what we really do in the hospital. Like, should we let the patient stay in the hospital for a while to wait for another episode, or should we just definitely in this case definitely dangerous and wrong to discharge the patient? But I'm just thinking of in real life, if there's no such episode happened in the hospital, what we may do. Yeah.
Yeah, absolutely, absolutely. It's a great teaching exercise, a great demonstration of cost-effective, high-value care of a patient, which I can sort of glean from this case, the testing that was done appropriately, and not to over-test as well with this patient. That I guess they teach you in this program. So I also want to applaud you, and both Jody and Mohammed. Great way of presenting the case. Absolutely stellar the way you delivered all the necessary information. So very effective. This is great communication in delivering the highlights of this case. So really great presentation. I thank you for bringing this case. And any questions about the program? I guess to get things jump started. Oh, I guess Vijay is asking for problem representation, but
Rami.
what do you? Yeah, go ahead, Deborah.
No, you always have some good questions, but something that we like to ask is
Yeah.
about research, if they have the opportunity to do research during the residency, if any of them can answer that.
Sure, I can jump in. Thank you. Guys, that was an amazing presentation. So yeah, we do have research. So as a community hospital, we have resources that are available to us through like we have, like I like to call it, the best of both worlds. So we have some resources from University of Miami itself in terms of databases and everything, and we have also resources from HCA in terms of statisticians, if you're interested in doing some research. We are also, so the way that our program works is that we are both located in JFK, which is our main hospital, but we also work at the VA. So it's kind of like 60-40% of our clinical work is there. and we have access to all VA resources, which are amazing, including like QI projects databases, which it's an enormous database. So to shorten my answer and summarize it, yes, we do have access to research, and we have all the support and all the eagerness and willingness to help everybody that wants to do research.
Claudia, I notice you have in-house fellowships as well. I think cardiology, interventional cardiology. Is that right?
Yeah, so we are a really big cardiovascular center. We have advanced cardiac therapies, and we're really big on cardio and neuro, but cardio mainly. We have general cardiology, we have heart failure, EP, and interventional.
Do you have any medical students? I think teaching is a big part of development as a intern resident, and those responsibilities just help us to grow our knowledge as well, and also as a future leader in teaching if you want to do academics. Do you have medical students that rotate with you?
We do, we do. Right now we're transitioning a little bit. VA has a few of the residents, and JFK we have a mix between Nova, which is another university that it's local, another med school.
And since you're interested, Deborah, also we were talking about POCUS. Do you have a POCUS curriculum? Or all interns, residents taught
Yes, we
or get
do.
experience?
Yeah, so that's something that it's we're really proud of. So actually this year we formalized, because before that we were teaching POCUS. We like my coach, even me, we like to call ourselves POCUS aficionados. But this year we finally formalized a curriculum that we are with like in the first 19 weeks of the year, we're one-on-one with the interns. It's called Immersion Camp, to help them to have a very smooth transition. And one of the things that we try to do, not only logistics stuff in terms of how to deal in a day as being an intern, but we do point of care ultrasound. We have a simulation center, we go there and then we scan patients. So we kind of like have a curriculum pretty much based on the ACP curriculum, a little bit with some adaptations to us with the resources that we have available, and we try to teach them. We also are incorporating what we call gel rounds to our didactics. So at least once a month, we try to kind of like divide ourselves in very small groups or 4 or 5 residents and try to go scan patients that we priorly like evaluated and assessed and have specific findings.
That's remarkable. Yeah, I love gel rounds. So yeah, the components of a POCUS instruction in any institution will be, of course, the conferences, and then sim lab, and then gel rounds is also a component. So I'm happy. We used to have auscultation rounds back in the day before POCUS, so having a cardiologist lead us around listening to murmurs, but now it's gel rounds. And I'll ask you, Jody, a question. So we have a large IMG attendance to these programs, and they're probably interested in. So do you have any, or maybe Claudia also can answer this, for IMGs, the most difficult thing is getting accustomed to the workflow that's presenting, writing notes, and things like that. Do you have in your program something that's catered for them, maybe an orientation that's separate from AMGs to get them up to speed with the workflow that's required of them?
I can say our program is very supportive in, any listening to any concerns and addressing them. So I don't know if there's any specific orientation. We all go through about a week and a half of orientation previously and training and all of that. But there's always someone willing to lend a helping hand and spend extra time. I know even for me, not being an IMG, but still needing some extra help prior to starting in the ICU, someone sat down and ran through the whole system with me, took time out of their busy day when they'd been there like 12 hours, just to run over how to do orders and those kinds of things prior to starting, so that on day one we weren't completely lost. They also ease you into the workflow very nicely. So when you start out, you don't take a full patient load at least in the first couple weeks, you take a lighter load so that you have more time to spend learning the system, which is very helpful. I don't know if Claudia or Rehan want to add anything.
The only thing that I would like to add is, so we have not only for interns, but also for like transitioning from PGY1 to PGY2, which is a big transition as well. So we have the immersion camp for the interns, which part of it is listening to sign outs, kind of like even before you are in like very hard rotations or core rotations, wards or ICU. You go, you listen to sign outs, and it's one-on-one. So it's really useful, and the feedback that we received is really good. And then for transitioning from PGY1 to PGY2s, so for example, our interns, they don't do night shift. So they start doing night shift as a second year. So that's a big change. So we developed this PGY2 boot camp, which is divided in two phases. One, medical knowledge in terms of, okay, they will be responsible for rapids and more like medical management, versus the other one, which is more logistic. Okay, you're in the middle of the night, so these are the series of things that you need to take into consideration. This is how to be efficient at night. This is how I preferably do things. So trying to find your way, and we do those sessions in very small groups too, and the feedback that we received was really good too.
Amazing, amazing. Just such a culture of pay it forward. So people teach you and you turn around and teach the junior members. That's just remarkable. So it's just helpful. And that you carry forward into any setting. Like Claudia, you go to pulmonary critical care, UAV, you will be teaching and mentoring many interns, students, and so on. So that's a very important part of what we do as a specialty. And I think Yasmin has a question.
Yes, I do. Thank you. We have heard that your program is a community program, but as an IMG, sometimes what we are quite on the line of what does that mean? Just for the sake of like just to know, because that's a big doubt I've always had. But I really have never understood exactly what does that mean.
Sure, I think I can help a little bit. So I think overall, the biggest change that compared to university programs where are completely university affiliated, not only university affiliated, but like owned pretty much by the university. It's the patient population, kind of like the division between clinical versus research time, dedicated research time that you have in terms of responsibilities overall throughout the 3 years if it's internal medicine. So for us, we are pretty clinical. That's our main goal, but we do also incorporate research on it, if that makes sense. It's not dedicated research time. We do have research electives. If you have like a project that you would like to develop, that's something that it can be given, it can be done, but overall it's very robust clinical training, if that makes sense.
Wonderful,
Yes,
wonderful.
thank you so much. Thank you, Claudia.
Yes, we're about 1:10, but one last question. Somebody mentioned, Mohammed, did you have to learn? Are you from Miami? Did you have to learn Spanish? I know we have a large Spanish-speaking population in the area, and also Haitian, right? So my French is really good, but Spanish is like great.
Well, I'm originally from Tampa, not too far from here. Just about 4 hours. But obviously, I didn't speak Spanish or Haitian Creole, or those language barriers are there. And I think in a short amount of time in clinical training, it's hard to sort of put yourself in the position to have an opportunity to learn those in addition to clinical things. But I think we have translation services on our cell phones that our program provides. It's pretty much whatever language services that we need are like a couple clicks away on our cell phones. So it's usually never a problem in the mornings because I can actually call my patients on my way. We do have a fairly diverse population over here that we serve in our hospital. But yes, we do have translation services that are used, and my Spanish is not at that level yet.
That's great to hear. Yeah, that any program, you don't want to feel like you're left to yourself to try and communicate with the patient. So you have all this support And also diversity is a remarkable component of your program, like you've mentioned. And I'm just so happy to have you, all of you here today, spend an hour with us, and then also be great champions of your program. And I'm also very happy to hear that community programs are excelling and competing with other programs in providing so many different services and having in-house fellowships and opportunities, research we covered, and this great case that you've presented, both of you as well. A great job on that. And I'm at a community program and just love trying to improve the program to attract great applicants and make it a great training program for everyone. So and I'm sure all of you will go on to provide great care to different communities all around the country. And I wish you a lot of success in your future. And again, I appreciate you all coming on here and representing your program.
Thank you so much for having us. It was a pleasure to be here today.
Thank you very much. Yeah, Gia, any closing remarks?
Yeah, I'm just really appreciate this opportunity to learning together with doctors and you, and yeah, very interesting journey. Thank you.
Thank you. Thank you again, Dr. Perry, Dr. Tiara, and Dr. Rehan. Take care. Have a great rest of your weekend. Bye.
Thank you, everybody.
Thank you.
Thank you. Bye.